Okay, good afternoon, everyone from home.
Good afternoon, doctor.
Okay, so,
Good afternoon, doctor.
so the lecture is only on thyroid gland, I think, if I'm not mistaken. Okay, so this is the thyroid gland, okay, in a summary. So we will discuss the gross anatomy and histology, okay? So it is very important. It's located on the anterior part of the neck, anterior to the trachea. So you can see this is the trachea. You can see the trachea ring. These are the cartilages of the trachea. Okay, in between cartilages we have connective tissue there, and this cartilage of the trachea, they are C-shaped. Okay, the end of the C is posterior. We cannot see it here unless you take transverse section or you look from the posterior. We'll see later. So the thyroid and above there, okay, this is the cricoid cartilage. This cartilage is cricoid. You see, cricoid cartilage of the larynx. So above here, this is the larynx here, the voice box. This is the laryngeal cartilage. And the proper name is thyroid cartilage. So here, you see, it's called thyroid, even though it's not touching the thyroid. So the main cartilage they are from the Adam's apple. You see, more prominent in males. And this is the Adam's prominence. Or thyroid prominence, or laryngeal prominence. This one is called the thyroid cartilage. Below it is a cricoid cartilage. Cricoid cartilage is like a ring, okay? But the trachea cartilage are C-shaped with the end of the C posteriorly. So you can see, and again, you can see the thyroid. This is the left lobe of the thyroid gland. This is the right lobe, okay? And what joined the two together is called an isthmus. Here, isthmus of the thyroid gland. And sometimes we have small lobe at the center here. This is called pyramidal lobe, okay? Accessory pyramidal lobe. What we can see again is that the thyroid is supplied with a lot of blood vessels. So look at arterial supply from superior, some coming from the superior, on the both right and left. So, some come from inferior, okay? You see, they come from inferior. Some come from lateral, especially the veins. You see, the veins are many also. So what we can see here about 4 arteries. This is the left superior thyroid artery. This is the right superior thyroid artery. This is called inferior thyroid artery. This one here, inferior thyroid artery. We also have middle thyroid. It's not shown here, but we have middle thyroid. So now you remember I told you that this is the arc of the aorta. This is the arc of the aorta. At the arc of the aorta, there are 3 branches, 3 arterial branches. The first branch after coming out of the heart by the arc of the aorta is brachiocephalic trunk. This one here, or innominate artery, brachiocephalic trunk, which divide into right subclavian artery, this one here, and the right common carotid. You see, common carotid. The right common carotid goes up, and in the neck it divides into internal carotid and external. Internal supply the brain, external supply the skull, the muscle of the skull outside. So you can see from the common carotid here, common carotid before bifurcation into internal carotid and external carotid, it gives rise to this artery here, superior thyroid here, superior thyroid artery. Okay. Now look at what happened here. After subclavian artery is given off by the brachiocephalic trunk, okay, at the outer border of the first rib, it goes laterally and become axillary artery. Before it becomes axillary, you can see it gives many branches, but some of the ones we are concerned with is this one here. It gives this artery here. It's called thyrocervical. Thyrocervical is supply the thyroid and the neck. Cervical is neck. So it's called thyrocervical trunk. You see. So the thyrocervical gives rise to many branches. 1, 2, 3, 4. So one of the branch is the inferior thyroid artery. So if you are asked what is the blood supply to the thyroid gland, you have to mention this. Inferior thyroid artery, a branch of thyrocervical trunk. If you can say, which is also a branch of subclavian artery, and it happens on both sides. Okay, and I told you there's a medial thyroid artery coming from directly from the common carotid. So you can see so many blood vessels supplying the thyroid. So it's having a lot of blood supply, and that's why when you operate on thyroid, to operate on thyroid, to remove, if thyroid is swollen like in goiter and you want to operate, we call it thyroidectomy. So thyroidectomy, we have total thyroidectomy if there is cancer of the thyroid, or subtotal in goiters. Okay, we call it subtotal because you are not going to remove all. Why? Because we don't want you to remove everything. We still need some remnant of the thyroid to produce T4 and T3. Also, posterior to the thyroid, we have parathyroid gland, 4 of them, 2 on the right lobe on the posterior part of the left lobe, 2 on the posterior part of the left lobe. So we want them. We still want to maintain the function of the parathyroid glands. One of the functions of parathyroid is to produce parathyroid hormone, which is important in calcium metabolism. If you remove them, the patient will have calcium problem. So if what do you call it? If you remove the whole thyroid, you have to give the patient thyroid supplement and parathyroid supplements. So in patient who has cancer of the thyroid, you will remove the whole, especially if it metastasizes. But in non-malignant condition, you can do subtotal. If you remove thyroid and block, because of this huge blood supply, when you remove, you have to make sure all these arteries are tied properly. Okay, you have to tie them properly so that they don't bleed. Okay, after I remove, you find that all these branches, you have to tie them with very strong sutures. If they are not properly tied, after some time, the patient may die. You know why? Because blood can accumulate below the skin. You know, you are going to suture back the skin. So the patient is also lying down. After operation like that, it's very painful. The patient is sick, has to be lying down, taken care of by the nurses in the ward. So if they are severely sick and there is bleeding, let's say one of the arteries is not properly sutured, it's not properly ligated, so it brings out blood. By the time blood collects here, it will compress the trachea and the patient cannot breathe, which is dangerous. So many patients can be seen either complaining of difficulty with breathing, or they are seen dyspneic. So you have to rush and open the wound. The solution is open the wound, go and ligate those arteries, and then close the skin back. Okay, so this is a lot of clinical application in the thyroid. And sometimes the thyroid can have viral infection, thyroiditis, or autoimmune thyroiditis, and it will swell up and cause. It can also have grave disease. Okay, so there are many things. As we go, I will mention. Okay, so how about the surface anatomy of the thyroid? Okay, look at this patient here. I mean, this person, not patient. So you can see the thyroid here below the skin. You actually the thyroid cannot be felt in normal person. If you touch your anterior part, you cannot feel the thyroid. And when you look through the mirror, also you cannot see the swelling of the thyroid, normal thyroid. That's why it is said that once you see swelling of your thyroid, something is wrong with it. Once you look through the mirror and you see, oh, look at the shape of my thyroid, butterfly shape, you know, there is swelling of them. Something is wrong with your thyroid. It's swelling up. Or if you palpate your thyroid by just casual touching of your anterior part, and you feel, oh, I feel my thyroid, most likely it's swollen up because it's very thin. It's very thin, like a sheet of paper. So, and it's just below the skin. So below the skin, between the skin and the trachea. Of course, there are muscles. I'll show you some muscles that cover the lateral part. But otherwise, the most anterior part here, including the isthmus, they are just covered by the skin. Okay. So I have mentioned all this, and it's located anterior to the trachea. It has butterfly-like appearance, consists of 2 male lobes connected by isthmus, and these are the function. And it's involved in calcium metabolism because it produces calcitonin. Calcitonin does the opposite of parathyroid. Okay, parathyroid is important when your calcium level is low. It will stimulate some cell, including osteoclast, to break down bone, so that there will be more calcium in the system. While calcitonin does the opposite. And if the calcium is high, it leads to the conservation of storage. Okay, so let's move on. Okay, so this is the cartilage. I mean that the posterior part of the thyroid here. So this is the anterior part we're just talking. This is the crico cartilage. This is the thyroid cartilage. This bone is called hyoid bone. Not yet. Not sure yet. But you can see it's connected with the thyroid cartilage here. If you look at the larynx or the posterior part of the neck, this is how the thyroid looks like. So this is the thyroid. This is the posterior part of the thyroid. You can see these are the parathyroid glands. Two on both sides of the thyroid lobe. So this is the left thyroid lobe. This is the right thyroid lobe, and you can see the gland, the parathyroid gland. The trachea, I told you now, the trachea, they are C-shaped, and the end of the C is posterior. So you see here, this is the end of the C of all the what do you call it? All the C-shaped cartilages. They are not complete. Posterior, they are not complete, and there's a deficiency here of the trachea, and in between them there is a smooth muscle called trachealis, which fills up the gap. Okay, so the trachealis which fills up the gap there. This is the posterior part of the cricocartilage. You see, it's a complete ring. You see, anteriorly it looks like this, posteriorly it looks like this. Even have a big surface here. Of course, there are additional smaller cartilage. This is the posterior part of the laryngeal cartilage. This cartilage, the posterior part is how it looks like. Okay, and this is epiglottis. Okay, let's move on. Okay, the same thing. I was just talking to you about the surface anatomy. So you can see in this fashion, you cannot see, but when you palpate, you can feel the trachea, and you can say, "Oh, this is the region of the thyroid." And okay, maybe that one later. I'll tell you that one. This is the lateral side of the larynx. Okay, so I'm not teaching larynx, but just for completing, I'll mention it here. So this is the thyroid cartilage I told you, which is also complete, anterior, posterior. This is the Adam's apple here. This is the posterior part. So the anterior part is here. And this is the trachea. Sorry, this is the cricocartilage. Sorry, this is the cricocartilage. This one here is the thyroid cartilage. Okay, this is the cricocartilage. This is the anterior, posterior part. This is the posterior part. This is the anterior part. So we are looking at here this way. This is the anterior part. This is the anterior part. This is the posterior part. We cannot see the posterior, but we saw the posterior part a while ago. Yeah, this one here. This one. Okay. Of course, there are additional small cartilage, but I think what we're interested in more is vocal cord. These are the vocal cord, okay, in the larynx. So the larynx house the vocal cord. You see here, the vocal cord contains the vocalis muscle, which give us the sound of our voice. So there's a skeletal muscle inside here. This full mucous membrane covering the vocalis muscle is inside here. So it is the vibration of that muscle that bring out the voice. That's why we call the whole larynx voice box. And the mucous membrane, remember the mucous membrane covering the larynx, the pharynx, the mouth, it's also covered the vocal cords here. So that's why if somebody has upper respiratory tract infection that brings out inflammation, serious severe inflammation of the mucous membrane, and it affects the fold. The fold over the vocal cord are called vestibular fold. You see here, vestibular fold. The fold of mucous membrane covering the vocal cord is called vestibular fold. So if they are inflamed due to upper respiratory tract infection, the patient voice will be lost temporarily. And when you go to the hospital, you complain to the doctor will ask you, the solution is you do voice rest. You hear sometimes the doctor will ask you to do voice rest, which means go home and stay and don't talk too much, talk less. When you talk less, this area will heal. The more you talk, the more injury, the more damage, the more loss of voice. Okay, so let's move down. So the same thing here. Just more about the larynx, actually. I think that this lecture, the one I delivered last time, we needed to talk about larynx. Your own deserves a thyroid, but I'm still teaching the larynx. So the thyroid cartilage has two laminae. Lamina means half. So this is half laminae. So we are looking at the left laminae now. Okay. No, sorry. This is the left. Yeah, this is the anterior part. This is the left. With anterior border fused together at an angle called laryngeal prominence. Okay, so I told you the laryngeal prominence is here. The posterior border are widely separated from each other and extend upward. So this one is showing, it's talking about posterior part of the larynx. This one here. So this is the posterior part is free. Okay, the posterior part is free. Only the anterior part is fused together. So this is one lamina. This one here is one lamina. This is another lamina. Okay, that's what we are saying there. Okay, lamini. Okay, plural is lamini. You just put e here. So it's formed by two laminae with the anterior borders fused together. So this is the anterior border here. This one here. Okay. You see, laryngeal prominence, Adam's apple. Okay. So this one lamina, left lamina, is the right lamina. Together they are called laminae. And I just show you posteriorly, there is no border. They don't join each other. They are separated, widely separated. See? Posterior border are widely separated from each other. The lateral surface has an oblique line to which the sternothyroid and thyroid muscle attach. So the lateral part of the ligament of the cartilage here has it gives origin to this muscle here, sternothyroid and sternothyroid. Okay, so so now I've talked to you about larynx. Now look at some muscles. You see, these are some muscles attached to the thyroid or arising and inserting on the thyroid cartilage. And this is our thyroid gland here. So this is the same thing I just mentioned, the same thing. But this point is important. The lobes of the thyroid, this lobes here, this one, this right, they extend up to the oblique. Remember the oblique we just mentioned here on the thyroid cartilage? So they extend up to the oblique line on the side of the thyroid cartilage and downwards to the sixth tracheal ring. So lower down, if you the first tracheal ring below the cricocardium is number 1. So this is number 1, number 2, number 3, number 4, number 5, number 6. So it spans from from above the trachea up to the sixth laryngeal cavity. Okay, so that is what we are saying. The extent of each lobe. So from the oblique line on the thyroid cartilage up to the sixth tracheal ring. Okay, that is the extent, vertical extent of the thyroid gland. And we say the thyroid gland is covered by pretracheal fascia, which fixes it to the trachea, so the gland moves with swallowing. Because of that attachment of the pretracheal fascia, you find that whenever you swallow, the thyroid gland moves. And that's why somebody comes with swelling on the anterior part of the neck, and you suspect it's thyroid, after taking history of the patient, you're supposed to ask you give patient some little water in a cup and ask him to drink and swallow while you are watching the person. Or ask him to swallow saliva, but it's more convenient to give them water. If you say saliva, some people's mouth is dry. So when you give him water, whenever he drinks, you find that the thyroid goes down. During swallowing, the structures here, including thyroid, they go down. So if this follows, the thyroid descend, the thyroid cartilage will descend, or the larynx will descend down. So it will descend together with the thyroid. If you see that the swelling you have here, each time the patient swallows liquid, it moves down with the trachea and the larynx. That is thyroid swelling. If the swelling does not move with the swallowing, then it's most likely not thyroid gland. Okay, so that's another clinical application. Okay, later I'll show you the pretracheal fascia, and I'll show you all the. You remember I explained to you how these branches are formed. All this one here. The only thing is that this diagram has division of the internal carotid from the external carotid. So this is the common carotid, and this is the external carotid here, and this is internal. Internal will enter the neck to go to the brain, and to go to the skull and supply the brain, while the external supply the outside structures. So remember, I told you sometimes in some people, okay, in addition to what we mentioned earlier, each lobe is conical in shape and has apex. Okay, it has apex, it has base, and anterior surfaces, lateral, medial, and posterior. So this is the medial surface here. This one. The lateral surface is along this common carotid artery, and posterior surface is opposite what we are seeing here. So this is the anterior surface. Okay, so we have anterior surface. Okay, posterior surface we cannot see there, and medial and lateral surface. No. It has lateral surface. Okay, lateral surface, posterior surface, and medial surface. Okay, so no anterior surface. So this surface is regarded as anterior. Sorry, lateral. So you can say anterolateral, depending on the book. I think this book just mentioned lateral. And we said that in some people, they have small pyramidal lobe, which is frequently present on the upper border of the isthmus to the left of the median plane. So this is the median plane along this fusion of the right and left thyroid cartilages, this one here. So if you draw a line like that straight, you can see that in some people, they have this small pyramidal shape. Yeah? This small lobe of the thyroid is called pyramidal lobe, and it's an accessory. Okay. And in some, when a patient has it, is to the left or to the right side of the median sagittal plane. Okay, so if you draw a line to divide the body into two equal halves, you find that the pyramidal lobe is on that side, either on the right or on the left side. And in some patients, it is connected to the okay, this one. Sometimes the thyroid gland is connected to the hyoid bone. Remember this hyoid bone by a fibrous strand, which is around octaglossal duct called levator-glandular thyroid. You don't need to know. If you know, it's okay. Okay, before I leave here, look at here. This is a nerve. Okay, this nerve is called superior-laryngeal nerve. This one is called left vagus. This is right vagus. So both of them, the right vagus is coming. Remember, it's coming together with this internal jugular vein and common carotid, together with the vagus nerve. Nerve number 10 is called vagus nerve. They form a neurovascular bundle in the neck. Okay, neurovascular bundle here in the neck. So this vagus nerve, the destination is to go to the stomach, esophagus, stomach, and the small intestine, supply them. So on its way, actually, it gives a recurrent laryngeal branch to supply the larynx, okay, and the thyroid gland. So that recurrent is below the left, it's below the arc of the aorta. So below the arc of the aorta, it gives another recurrent branch. Apart from this superior laryngeal nerve, sorry, superior laryngeal nerve, okay? So this recurrent laryngeal nerve, it goes back and supply this structure. The same thing here, we have the right. The right hooks below the brachiocephalic trunk. The right, so the left hooks below the arc of the aorta. Okay, very important. Now, during that operation, I told you thyroidectomy, if the surgeon is not careful, he can injure this nerve. See, because they are posterior. And when they are injured, because they supply that vocalis muscle in the vocal cord, in the larynx, patient will lose their voice. And that can be permanent sometimes if the nerve were cut. And that's why thyroidectomy must be handled by experts who know the anatomy very well. Because injury to those nerves will cause loss of voice, which is permanent. It's not like the one I told you, temporary, when you have upper tract infection. After the infection, your voice goes back to normal. This one, if this nerve, the hook, the recurrent that is given up, is injured, it can be troublesome. So this is the transverse section of the thyroid showing a relationship. Okay, some relationship means what are the structures on the lateral side of the thyroid? What are the structures that are on the posterior part of the thyroid? What are the structures that are on the lateral part? Sorry, medial part. So this is the thyroid gland. This is the vertebral body. So this is the posterior. This area is the posterior surface of the person. This is the anterior surface. So we are looking at this from above. You can also look at it from below. If you look at it from below, that means this is the right side and this is the left side. Okay, from below. If you look at it from above, also the same. This is the right side, this is the left side. So depending on your orientation, which one is easy for you, okay? But what is important is, if like me now, I'm looking at it from above. So this is the right thyroid gland. This is the left thyroid gland. This is the trachea here, okay? So you see the trachea is C-shape with the end of the C posteriorly filled up by smooth muscle called trachealis. This one here. So this is the trachealis here. And these are the C-shape. Okay, and this is the thyroid here. So this is you know, this posterior surface, this is the posterior surface. The whole of this is lateral surface, okay? Called lateral surface. And this area, the whole of it, I think they say lateral surface, yeah. And this is the medial surface. This one here is the medial surface. So the posterior surface, or let's talk about them now, and then later I will explain to you more when we go there. So in addition to this relationship, look at the neurovascular bundle. This is the internal jugular vein. This is the common carotid artery, and this is the vagus nerve. So if we say this is the right side, this is the right vagus nerve. Look at what happened on the left side. Internal carotid, common carotid artery, internal jugular vein, and the vagus. So this is the neurovascular bundle of the neck. Okay, and they are surrounded by a sheet of fascia. This green structure here covering it is called the sheet of fascia. Okay, and now look at the thyroid gland. It's also covered in the green sheet of fascia. This is called pretracheal fascia. Pretracheal fascia. And I told you, whenever we swallow, the trachea moves down with our swallowing. And because of the attachment of the thyroid to the trachea or pretracheal fascia to the trachea, it moves together with the thyroid gland. Okay, so that's what I was explaining. If someone has swelling on the anterior and you want to differentiate whether it is thyroid gland or another structure, you ask the patient to swallow water and look at the movement of the swelling together with the trachea. If they move together with trachea down during swallowing, that is most likely. Then you just do further investigation to pinpoint what is going on. Now, in addition to all this fascia, there are muscles. There are muscles that also are related to the thyroid gland. So look at this one here. It's sternomastoid. It's also covered by fascia. So sternomastoid muscle is covered. Anteriorly, that one is more of lateral, in between, with the neurovascular bundle in between the thyroid and the muscle. Okay, and then anteriorly, on the anterior part here, you can see it's related to the sternum muscles. Sternothyroid, sternohyoid. We'll see them more. Look at them here. So look at your thyroid in normal anatomical position with muscle intact. These are the muscles of the neck. So you can see this is the laryngeal cartilage here. So that we call it thyroid cartilage. Remember, on both lateral part, on right and left lateral part, we have muscles. This muscle is sternohyoid. Okay? This is because it's arising from sternum to the hyoid bone. Remember, this is the hyoid bone. So we call it sternohyoid. Sternohyoid. Then we also, lateral to that, we have another muscle. It's called omohyoid. The omohyoid has two bellies, okay? Thick bundle of muscle separated by tendon. The superior one here attached to the hyoid bone is called superior belly. You see, superior belly of omohyoid. Look at here in the inferior triangle here, lateral to the sternothyroid. This is sternothyroid muscle. Lateral to its border, we have another belly there. That's called inferior belly of omohyoid. Okay, so we are not interested in inferior belly. We're interested in superior belly. So we have sternohyoid. We have omohyoid. Okay, and we also have another muscle here. But this one is deeper muscle. It's called sternothyroid from the thyrohyoid. Thyrohyoid from the thyroid cartilage to the hyoid bone. Okay, so this one is called thyrohyoid, while these two are called strap muscles. So here, those are the muscles here. You see, those are the strap muscles here. These four here. Two on the right side, two on the left side. Look at this one here. So this is omohyoid. Sorry, this is sternohyoid. Sternohyoid. No. This is thyrohyoid. Actually, depending on what you can assume this is the upper part. If it is the upper part, this should be sternohyoid and omohyoid. But if you think it's near the hyoid bone, so this will be thyrohyoid, and this will be sternohyoid. Okay, so but you remember there are three strap muscles, so they didn't even put them properly here. This muscle there are three. On both sides there are three. So on the right side we have this one here. On the left side we have this one here. On the left side you can see here, this is the left sternohyoid from the sternum to the hyoid, and then the next one is superior belly of omohyoid. Okay, and we have inferior belly here. And then the next one below, if you remove this one, it will be exposed properly. Thyrohyoid, from thyroid cartilage to the hyoid bone. I think we have it. Let's see. Okay, not very clear. Not very clear. Let me see. Yes. Okay, great. I have put it here. So this is the I think this is clear structure. I didn't know I have put all this. So this is much more clearer. Look at the thyroid gland here. Okay. Now remember. This one we are looking from above. Okay, let's assume this is the left side. Okay, this is the left neurovascular bundle. This is the right neuromuscular bundle. So this is your right structures here. Can you see the arrow? I mean the laser, and this is the left structures, and this is anterior part. Anterior, you see, anterior jugular vein, and this is the posterior jugular vein. The fascia that separates vertebral column from structures in the thorax is called prevertebral fascia. While the fascia here that separate the trachea from the structure is called pretracheal fascia, which also enclose the thyroid gland. So look at the strap muscles. First of all, we have sternocleidomastoid, you remember? Sternocleidomastoid. Then we have sternothyroid, remember? And omohyoid. So omohyoid is the most lateral part. It's still in contact with the lateral surface. So that's why statistically, the thyroid gland has 3 surfaces. From here, middle part, up to here, this is the medial surface, okay? Medial surface. This is the posterior surface, this one here. This is the posterior surface. While from here up to the center here, central part, this is the lateral surface of the thyroid gland. So the lateral surface is in contact with strap muscle. These muscles are called strap, okay? So they are actually 4 in number. The most medial, now let's say the most medial close to the midline, is the midline here, is the sternocleidomastoid. Then the next one is thyrohyoid, from thyroid cartilage to the hyoid bone. And the last one is the omohyoid. And all of them are covered externally by sternocleidomastoid. Okay, so look at them here. So this one is called sterno, from the sternum here, and the clavicle. It has 2 heads. This is the medial head, this is the lateral head. The medial head is from the sternum or manubrium, and the lateral head is from the clavicle. Okay, that's why it's called sternoclavicular muscle. But remember, we call it sternomastoid because it's attached to the mastoid bone, the bone posterior to the ear. Okay, so you can say sternocleidomastoid or sternomastoid without mentioning this head here on the clavicle. But it's better to mention the 2, sternocleidomastoid. So it's the most superior, most outer part. But you can see it's not actually covering all of them. Yeah, in situ, you find that they are not very covered. This muscle here, I mean, this is omohyoid, sternocleidomastoid, superior belly of omohyoid, and this one here in between is superior. So deeper is the thyrohyoid. Thyrohyoid. Let me see whether we have removed. Okay. Okay. So relation of the medial surface of the thyroid. Okay. Remember medial surface. So this is the medial surface here. So you can see below we have the trachea. So this is the trachea is on the medial surface. The esophagus. This is the esophagus here. The esophagus is located between the trachea and vertebral body. Look at how flattened it is. Okay, so that's the esophagus. So esophagus is on the medial surface within medial surface posterior, and the recurrent laryngeal nerve, this nerve here. So 3 structures: trachea, recurrent laryngeal nerve, and the esophagus. They are on the medial surface of the thyroid gland. Posteriorly, okay, above actually before we leave here, above we have the thyroid cartilage, inferior constrictor muscle of the pharynx, and external laryngeal nerve. This one you can go and study them separately. Okay, posterior. So this is a relation with the lateral visual muscle. So posterior is the neuromuscular bundle actually. This one here, neuromuscular bundle. So internal common carotid artery, internal jugular, and the vagus nerve. Okay, in the sheath. All of them are surrounded by a sheath. Sheath is connective tissue. Okay. Okay, so the posterior surface, in addition to common carotid intercarotid sheath, prevertebral muscles. There are prevertebral muscles here, but not represented. Superior and inferior parathyroid glands. You remember superior and inferior, which are attached to the capsule. You see, embedded in the posterior wall of each of the glands or of the lobes. Now, the artery I've already mentioned, the blood supply is through arteries from the superior part and from the inferior. Let's see. Superior thyroid artery, see, from the external carotid artery. So that means a branch of the external carotid accompanied by external laryngeal nerve. What are inferior thyroid artery? From the thyroid cervical, which I told you, from first part of the subclavian. And they said it's said that it ascends to the base of the gland. So it goes until it is the base of the gland, like here. And it's accompanied by the recurrent laryngeal nerve. You remember the recurrent laryngeal nerve? So it goes there. That's why in the operation you have to be very careful with the nerve. We have an artery also called thyroidea artery, which is also from the innominate artery, which is from here, from the brachiocephalic zone. Another name for brachiocephalic artery is innominate artery. Okay, innominate artery. This thing is not. Okay. Innominate artery. Okay. So thyroid artery can arise from around here, from innominate artery, and go up there. Veins. How about blood drainage? I mean, drainage of deoxygenated blood. You can see the corresponding veins. These are the inferior thyroid veins. This one here. These are middle thyroid veins, accompanying middle thyroid artery, and these are superior thyroid veins. You can see other veins are draining the larynx, but the one we are concerned with are this one that drain the thyroid gland. Okay. So applied anatomy, I have mentioned all this. In operation on the thyroid gland, care must be taken to avoid damage to the recurrent laryngeal nerve. You remember? External laryngeal nerve, parathyroid gland. If you injure parathyroid gland, the patient will have, if the patient loses 2 or more of the parathyroid glands, there will be deficiency of parathyroid hormone, and he will have a calcium problem. He cannot process calcium. So they will go into something called tetany, sustained muscle contraction. So it's treated by extra, what do you call it, calcium supplement. If I told you, if the recurrent laryngeal is damaged, that can lead to loss of voice, which is dangerous. Okay. So this is if you open the thyroid gland, you find that the gland is like this. It has multiple how do you call it, thyroid follicles, multiple cavities surrounded by low cuboidal epithelial cells. Okay, so this is called thyroid follicles. So the hallmark of thyroid histology is presence of multiple thyroid follicles. Anybody talking? Did somebody ask question or say something?
I think somebody just accidentally opened their mic. That's all.
Oh, okay. Okay, is everything clear so far?
Yes.
Yes, doctor.
Okay, bagus. So we are going to histology now. We go down. I mean, we go deeper and see what happened in the thyroid. So you can see the thyroid gland is made of multiple follicles. Okay, in between follicles there are also cells. Okay, so histologically in between follicles there are cells. Okay, the cells of the thyroid, the cell that produce the T4, T3, we call it C thyrocyte. Okay, and the cell in normal situation, the cell look cuboidal, cuboidal epithelial of follicles. But this cell, they continue to produce thyroid secretions, which is called thyroglobulin, which is stored in colloid. Colloid together with other secretions, liquid secretion. And when these follicles are filled up, this cuboidal epithelium can become low cuboidal, okay, very low. And when it is empty, they become tall, like columnar cells. Okay, so they change shape depending on how filled up the follicle is. Okay. So this is drawing. Okay, this is drawing just to show you what is here. So you can see the outer part of the thyroid gland is covered by connective tissue. So this is connective tissue, and we call it capsule. Okay, connective tissue capsule. And then we said inside is made of multiple follicles. You see, these are the follicles, and these are the cells. Look at the position of the nuclei. It's at the center of the cell. Okay. And in between follicles, we have blood vessels. Or in between capsule and follicle, we have blood vessels. All these are capillaries. All the endocrine glands, they have a lot of blood supply. They have a lot of capillary network, so that whatever is secreted is taken to every part of the body. Remember, they produce hormones, and this hormone has to be taken to every part. Sometimes the site of action is far away, so they have to be carried. And we want it to be carried immediately. That's why a lot of blood vessels. So these are capillaries. You can see this capillary has single endothelium. Look at the nucleus of the endothelium. This one also single capillary, single cell capillary here. This is the same thing here, the same thing here. And in between follicle, we say there are cells. This cell here, this one here. They are called thyroid. Okay, sorry, these are T thyrocyte, okay, please. The one that form the follicle, the one that produce T4, they are called T thyrocyte. While the one outside is called C thyrocyte. This is the one that produce calcitonin. Okay, the parathyroid hormone, the parathyroid gland produce parathyroid hormone, sorry. So you can see all this. And inside here, we said there are, this cavity contains thyroid follicles, which is thyroglobulin with the unprocessed T4, T3. So this is just to show the regulation of the thyroid, which I don't know what I taught you in. This is from the endocrine lectures, but it's very simple, okay? Just know that the hypothalamus is the one controlling all the endocrine system. So the hypothalamus control anterior pituitary and also posterior pituitary. Okay, the anterior pituitary, not posterior. The posterior is storing oxytocin and the ADH, antidiuretic hormone, and they are important. ADH is for water conservation, while oxytocin is important in labor, in contraction of the uterus during labor. While the anterior lobe is the one that produces a lot of hormones, including the hormone that control the thyroid function. Okay, T4, T3. This T4, T3, they are not just produced like that. They need instruction from above, from the anterior lobe of the pituitary gland. So the anterior lobe of the pituitary gland produce thyroid stimulating hormone. Okay, here TSH, thyroid stimulating hormone, which will go to those follicle cells, the simple cuboidal T thyrocyte, stimulate them, and they produce T3 and T4. Okay, if the T3 and T4 concentration increase in the blood, what happens? The homeostatic system will come in. So normal T3 and T4 concentration, normal body temperature, everything will be okay. But if it is high, there is an impulse sent to the parathyroid and also the anterior lobe to decrease T3, T4 concentration. So they will decrease the supply of TRH. TRH is thyrotropin releasing hormone. Okay, this is thyroid stimulating hormone. This thyroid stimulating hormone cannot be produced unless hypothalamus release this hormone also. This hormone is called thyrotropin releasing hormone. So for the pituitary and pituitary to produce this thyroid stimulating hormone, it needs instruction through this TRH. Okay, and the T3, T4 also cannot be produced without the TSH. So you can see if this one is malfunctioning, no TSH, no T4, T3. If TSH is also not functioning, no T3, T4. Okay, so sometimes you can have normal TRH but abnormal TSH if the problem is with the anterior pituitary. Okay, so that's just, by the way, this simple. The parathyroid gland I just mentioned here. Go with a few minutes. Parathyroid gland, they are 4 in number, and they are posterior to each lobe. You see, attached to the connective tissue. Look at here. This is the thyroid follicles, and you can see this is the parathyroid gland. So it's actually inside the parenchyma of the thyroid gland. Deeply is what do you call it? Attached through connective tissue. Okay, so that's how they are related to the thyroid gland. So we just mentioned they lie posterior to the surface of the thyroid gland, and they are surrounded by connective tissue capsules. You see, they contain thick branching. If you open parathyroid gland, what do you see? They are composed of 2 types of endocrine cells. We have one type which is small, a lot of them, abundant, parathyroid or chief cells, and they produce the parathyroid hormone. We also have another cell which is less abundant, which is called oxyphil cell. And some books write that they are likely to be the immature inactive principal cell. Okay, we don't know. So we remember I mentioned the function of parathyroid gland. Parathyroid increases calcium level and is essential to life. So when I write PTH here, it means parathyroid hormones. So if there is decrease in calcium level in the body, the parathyroid gland will produce parathyroid hormone, which will go and stimulate osteoclasts, which is a cell in the bone to break down some bone and release calcium. Calcium is stored in the bone. Okay, you see, stimulate osteoclasts to release calcium from bone, actually to destroy bone. The osteoclasts destroy bone. Okay? And another function of parathyroid is decrease secretion of calcium by the kidney. It goes to the kidney cells and stimulate them to decrease excretion of calcium, because we want to conserve calcium. Calcium is low. And it also activates vitamin D, which stimulates uptake of calcium by the intestine. For the intestine to take in calcium that is in our food, it requires vitamin D. And it requires complete vitamin D, which is called 1,25 dihydroxycholecalciferol. Okay. Okay, so I think those are the things. Quickly, I'll just mention to suprarenal glands. Okay, just for completion. The suprarenal glands, you see, they are on top of the pole of each kidney. So this is the right kidney, this is the left kidney, and they have different shape. This one is pyramidal. On the right, they look pyramidal in shape. On the left, they look rectangular. They are rectangular in shape. But otherwise, they are just attached. They are also like the parathyroid. They are attached to the capsule of the kidney, but not within the tissue of the kidney. Okay, but they are attached to them. You cannot just simply separate them. No. Look at on average, each parathyroid gland, they weigh 3.5 to 5 grams. So they are not very heavy, and their height is about 3 to 5 centimeters. The width is about 2 to 3 centimeters. And you see, they are also enclosed in a fibrous connective tissue capsule. Okay, they are also having their own capsule. So this is how they look like. Look at their blood supply, okay, and their shape. Okay, I taught you kidney last time. You remember? Look at the left kidney is more superior than the right. Okay, so they are supplied. You see, they are supplied by branches from the brachiocephalic. You see, this is the brachiocephalic. Sorry, that's brachiocephalic. Celiac artery. Celiac artery is the first branch of the abdominal aorta, followed by the second branch is superior mesenteric, this one here, and then the last one is the inferior mesenteric. Okay, so from that celiac trunk, you see this inferior phrenic artery. This one actually they are called inferior phrenic because they are going to supply the diaphragm. Okay, so they go to the right side and left side to supply the diaphragm. That's why they are called inferior phrenic. But on their way, they give rise to suprarenal, you see, superior suprarenal artery. So this inferior phrenic means artery to the diaphragm. Okay? On the right, on the left side, you see, it gives how many branches? 1, 2, 3, 4. 4 branches to supply the left suprarenal gland. What are on the right? 1, 2, 3. We can see 3 branches supplying the right suprarenal gland. In addition to this, look at here. This is the artery. This is the renal artery. From the abdominal aorta, there is a renal artery that supplies the left kidney here. You see. Also, there is right renal artery. The right renal artery is longer. Why? Because the inferior vena cava is closer to the right kidney. The aorta is closer to the left kidney. Okay. Remember, I told you this one a few days ago. And look at here, the artery, the pelvis of the ureter is posterior to the renal artery. So the renal artery is anterior to the pelvis of the ureter. You see the ureter? This is the ureter, this is the pelvis, the upper part. So, but we are talking about blood supply. So the right renal artery goes posterior to the inferior vena cava, because you can see here, you can only see its shadow. It's posterior to the inferior vena cava and is longer than the right renal artery. Why? Because the right renal artery, the left kidney is close to the abdominal, so it takes short distance to reach the kidney, while this one takes longer time. The opposite is true for veins. The left renal vein, which is coming from the left kidney, because the inferior vena cava is closer to the right kidney, but farther away from the left kidney, the left renal vein is longer. And the left renal vein is anterior to the aorta. So after leaving the left kidney, it travels anterior and crosses anterior to the abdominal aorta to enter the inferior vena cava. Okay, unlike the right renal vein, you see here, it's just anterior to the renal artery and it enters and it's shorter. Okay, so we have longer right renal artery and longer left renal vein. Okay, and we have shorter left renal artery and shorter right renal vein. Okay, these are the things I was asking you the other day. Now, what is interesting is that this renal artery supply inferior, you see, inferior suprarenal artery. So there are two branches, two or more branches from the renal artery to supply the suprarenal gland. You see, I told you every endocrine structure, every endocrine gland has massive blood supply. Why? Because we don't want the hormones produced cannot be taken to the site of action quickly within a short period of time. The same thing here, two arteries, okay? And there are veins. You can see that these are veins. So these are inferior suprarenal veins draining into the left suprarenal, left renal vein, okay? So these are just some of the things you go and read more, okay? Okay, lastly, if you open the suprarenal gland, it has a cortex. It has cortex and medulla. This medulla is the where adrenaline and noradrenaline are produced. The cortex produces hormones, okay? So the cortex is about 80% and is yellow in color, and the medulla is about only 10 to 20%. You see, it's this. And there is fibrous capsule. This is the fibrous capsule covering the gland, okay? And if you open, it has 3 zones. Physiologically, it has 3 zones. This is the capsule. This is the outer part. So this is the first zone here. This is the second zone, light yellow, and this is the deeper zone. So look at the zone here. Zona glomerulosa, the darker. You see here, the darker here, this dark area here, just below the capsule. Here also the dark area here, bluish here, this one here. So this is called zona glomerulosa. Then it is followed by large, what do you call it, broad area called zona fasciculata. Okay, this one here, from the end of this bluish areas here, up to this area, all this is zona fasciculata. Zona fasciculata. And the last one, this is the yellow area here, this one here, is called zona reticularis. Then this area here, which is that brown here, is the medulla, where the adrenaline and noradrenaline are produced. Okay, this one here, this one here. You can see it has also a lot of blood supply. Okay, a lot of blood vessels. Okay, so that's the suprarenal cortex, and this one is where we have the suprarenal medulla. So look at what I wrote here. Zona glomerulosa produce mineralocorticoids. So aldosterone is produced there. Okay, aldosterone, one of the examples. The middle zone, zona fasciculata, produce glucocorticoids. So like cortisol, example, cortisol is produced there, cortisol. The last one is zona reticularis. Androgens are produced there. Okay, androgens are male hormones. Okay, and that is why if this region, if in some women who have something called virilism, if this area is very well developed and a lot of androgens produced, then the lady or the woman will exhibit male characteristics because she has excessive androgen. We don't want androgen in females. Okay, if it is a man, no problem. He will look more man. Okay. Okay, so I think of course this one, chromatin cell produce epinephrine and norepinephrine. Norepinephrine and epinephrine the same thing as adrenaline. This one, epinephrine is the same as adrenaline. No epinephrine is the same thing as no adrenaline. So they are produced by chromatin cells. So those cells in the medulla, they are called chromatin cells. And they are nothing but modified ganglion sympathetic cells, okay? And they secrete all these catecholamines. Okay, and the catecholamines are very important in fight, flight, and fight, flight, and fright response. Fight, flight, and fright response. Okay, any question? Any question?
I have a question.
Somebody has a question. Yeah, I'm listening. Okay.
Okay, actually I have 2 questions here. So my first question is, does everyone have the pyramidal lobe? Because from what I've read from the textbook, only 50% of thyroid glands have the pyramidal lobe.
Of course,
And
not
then-
everybody has. That's why I mentioned not everybody.
Sorry, doctor?
Not everyone. Some people have, some people don't have.
Oh, okay.
So what you read is
So like,
correct.
what makes it different though? Like
Genetic makeup.
people who
Genetic
have it.
makeup. That means those people, they have genetic makeup. Maybe they inherited some gene that will allow them to grow it. Maybe from their parent have in their gene there is extra section of the DNA that encode the production of that pyramidal lobe. Okay.
But does it have function? The pyramidal lobe.
Yeah, it produce T3 and T4 also. It has thyroid follicle inside it.
Oh, so like those people who do not have this pyramidal lobe, they will like sort of linking off the hormones.
No. What you have is enough. Without, don't you see in subtotal thyroidectomy, sometimes if the thyroid is due, you can reduce it and no problem. It's just like kidney transplant. One kidney is enough for us, okay? The liver, if somebody has no liver, someone can donate liver to him. He can donate 1/4 of the liver and give someone. So 1/4 of your liver is enough for someone. That means the liver we have is more than enough for us. You understand what I'm saying?
Yeah.
The organs of the body, some of the organs of the body, except maybe the heart, the liver, let's say the kidneys, maybe adrenal gland, what we have is more than enough. I mean, you can donate to someone and still have enough to take care of our system. That's why one can live with one kidney, but we all have 2 kidneys. That means these 2 kidneys are much more than what our system requires. But they are just like jet engine, you know, in case one fails. Okay. Second question.
My second question is, when we describe the microscopic and macroscopic of thyroid glands, do we have to include the anatomy of larynx, like the description?
No. It's just for completeness. Because you see, your lecture setup. That's why sometimes when they are reviewing the curriculum, it's good to bring people like us into the system. But sometimes they review the curriculum in our absence, and they exclude an essential part. But I know you require all this, because if I just give you lecture on thyroid gland without talking about what happened above, what happened below, it's not nice. So we just fill up this because as a doctor you don't have syllabus, okay? Do you know that all of you, please, you should know that as medical student or doctor, we don't have syllabus. The whole human body is to be learned. So even if I don't teach you, let's say I didn't teach you this suprarenal gland, you have to go and learn by yourself. So whatever I haven't taught you, you have to learn it by yourself. That's why the question can come sometimes from what you are not taught, but you cannot say, oh, I was not taught, because you are supposed to know everything. Okay, any more questions, please? Okay, so in the absence of any question, I think we can stop here. I will drop the notes with the class rep. And since he has recorded, you can just share with them, please, the recording. Amar, you share the recording, okay?
Yeah.
Okay. So thank you, everyone.